All right, this is part two of the exam 3 review. I know I said I was going to do this at the next class, but I figured maybe some of you want to get a head start on reviewing some more of this. So I'm just going to go through some rest of these review questions. There's just a few more. I think there's 18 more, so there's not too many more that I want to go over. All right, so the next one is talking about the glomerulus, and you'll see the term glomerular autoregulation. What does that mean? It means the factors that regulate the GFR, right? What causes the regulation of getting blood into the glomerulus? And we talked about a couple different things. We know that in order to feed the glomerulus, we have to make sure we have ample blood supply coming from the blood, going through the afferent arteriole into the glomerulus. And so one way that we can regulate or affect GFR locally is through vasoconstriction and vasodilation. So with vasoconstriction, we close off the afferent arteriole. We make the blood vessel more narrow. And in the process of making the blood vessel more narrow, we actually cause the GFR, the glomerular filtration rate, to decrease, to go down. So we make less urine, okay? And then if I want to increase production of urine, I want to increase GFR, then I'm going to trigger vasodilation of the afferent arteriole. So there's local factors that regulate that, but there's also going to be factors such as your sympathetic nervous system that might have an effect on that. Remember, your sympathetics, when they fire, they're going to cause vasoconstriction, and that includes at the afferent arteriole. So that could be something that can affect it. But the major thing that's going to affect GFR via autoregulation is the blood supply occurring at the glomerulus, and we can regulate that by vasoconstriction or vasodilation of the afferent arteriole. One of the hormones that we talked about in the previous one, we talked about aldosterone, and we talked about atrial natriuretic peptide. But there's also, we also have talked about in class, antidiuretic hormone, ADH, also known as vasopressin. Okay, so what is the purpose of ADH? ADH, vasopressin, is going to, especially when it comes to the kidney, is going to go to the level of the kidney, and it is going to increase water reabsorption. Now I'm going to make a quick change here because I realized that in this version, I had it listed as resorption, but I think you know the term as reabsorption, so we'll just leave it at that. So if I increase reabsorption of water, so reabsorption is going back into the bloodstream, that's increasing blood volume, one of the things we should see is that urine formation will actually decrease. We'll actually get less urine formation as a result of ADH. So ADH and aldosterone have similar effects in that they're going to increase blood volume, which increases blood pressure, and it's also going to decrease urine formation, okay? I don't think I need to review this, but you should know the flow rate of the going through and starting at the renal corpuscle, going from the afferent arteriole to the glomerulus to the Bowman's capsule, and then through the nephron out to the papilla and even out to the urethra. You should know that pathway. I think we've gone over it enough times. All right. You should reassess and review the things that are secreted and reabsorbed at different levels of the nephron. So remember we talked about things that are reabsorbed and things that are secreted as they kind of go throughout the proximal convoluted tubule, the descending limb, the ascending limb, and you have a thick and a thin segment. And then you have the distal convoluted tubule and then the collecting ducts. you want to review, at least in the from the standpoint of the PowerPoints, and even in your book, what sorts of things are reabsorbed and what sorts of things are secreted in each thing. So like, as an example, like, of everything that gets filtered through at the level of the glomerulus into the Bowman's capsule, it goes into the proximal convoluted tubule. Most of the things in the proximal convoluted tubule are going to get reabsorbed. Okay, so we're talking about water, sugar, sodium, chloride. Most of those things, I think the number in your book is like 65% is reabsorbed at the level of the proximal convoluted tubule. But what we don't want to reabsorb is waste product. So if there's any urea or uric acid in there, that we're actually going to not reabsorb the toxin. Okay, we're going to keep the beneficial stuff. So like water, sodium, chloride, calcium, hydrogen. We'll keep the important stuff, but we want to get rid of the waste products. So that's another way to remember. So at the proximal convoluted tubule, most of the beneficial things are reabsorbed. Okay, if we need to get rid of excess, including excess beneficial sodium or excess beneficial chloride or excess beneficial hydrogen, potassium, then we can get rid of it later on. But at the proximal convoluted tubule, we're just primarily focusing on reabsorption. One of the things that we need to pay attention to, and I mentioned this in the previous review video, is that at the level of Bowman's capsule, we're creating this filtration membrane, right? So we got Bowman's capsule, we got the podocytes sitting on top of the glomerulus. So we got a lot of resistance of stuff getting into the nephron to begin with, okay? And that's intentional because the only thing we want going into the nephron is liquid, electrolytes, and waste products. We don't want proteins and we don't want cells going into the nephron. That's not what the nephron is designed to work with, okay? So at the level of the Bowman's capsule, the thing that definitely should not be getting in there are big proteins like albumin and then blood cells, more importantly. So cells are really big compared to these ions. Obviously, we know this because that ions can pass in between the cells. So they need to be really, really small getting into the nephron loop. So we do not want blood cells or other cells, white blood cells. They should not be getting into the nephron. At the end of and this kind of goes into knowing the flow of blood, then filtrate, and like kind of the layers of the kidney. So remember we talked about from the renal pyramid, at the tip of the pyramid, you have the renal papilla, and the renal papilla will drain into one of two structures. Usually it's going to go into a minor calyx first, then it'll go into a collection of minor calyces will drain into a major calyx, and then a collection of major calyces will go into the renal pelvis, okay? So if you get a question about what's directly connected to the renal papilla, your better answer, at least at this point in understanding without there being an image associated with it, is the minor calyx, okay? Major calyx will be listed there, but the better answer is minor calyx because the minor calyx could never be past the major calyx, and the minor calyx would always be right up against the renal papilla. Again, going back to the reabsorption secretion stuff. So like going down the descending limb of the loop of Henle, if you remember, the main thing that's being reabsorbed is water, okay? So as we're going down the pathway, as we're becoming more and more concentrated, as we go down into the depths of the renal pyramid, we're going to see down the descending limb of the loop of Henle or the nephron loop, we're going to see water reabsorption, okay? You should know the three terms associated with urine formation. Remember, those three terms are filtration, which really only, or actually not really, but only occurs at the Bowman's capsule, the glomerular capsule, and the glomerulus, okay? So that's where that occurs. And then you have reabsorption and secretion that occurs along the rest of the nephron, particularly proximal convoluted tubule, loop of Henle, or the nephron loop, and throughout the throughout the whatever it's called, throughout the loop of Henle, nephron loop, and then the distal convoluted tubule, and then the collecting duct as well. But filtration is only occurring at the glomerulus. So filtration, reabsorption, and secretion. The reabsorption means that it's moved into the bloodstream. The secretion means it's becoming urine at some point. All right. Okay. Good. I'm just making some notes here. Oops. Nope. Okay. Did that one. Okay. We didn't really talk about this, and I have to double check if it's in the book, in your textbook. Actually, I'm going to do that real quick. So I'm going to pause this. Okay, so you don't have to wait too long. You don't have to wait at all because I paused it and there's no delay on your end whatsoever. It says, or one of the questions, and this is in your book, about what stimulates micturition. So micturition is the process of being told your body is telling you that you need to go pee, you need to urinate. So the things that are going to trigger that are the primary one that we're all mostly familiar with is that your bladder will actually start to distend or stretch, and then that stretch actually sends nerve signals to the sacral plexus that sends up or tells the nervous system that you need to go to the bathroom, and then it creates a cascade of effects that eventually leads to the relaxation of the sphincters that allows for the urine to leave the bladder and then exit the urethra. Now, in addition to the stretching of the urinary bladder wall, you're also going to see the effects on the ureter. So when the ureter basically contracts and or it gets stretched and then it gets contracted, that's another trigger for needing to go to the bathroom. Now, that's also what happens when someone has urinary tract infection. That ureter wall might actually go into spasm, which creates the sensation they need to go to the bathroom, even if someone doesn't need to go, or at least doesn't need to go as urgently as the situation would suggest. So the ureter wall can contract, which is a trigger for the micturition reflex, as well as the renal pelvis becoming dilated with urine. So it gets stretched as well. So really anything along the exit point of the kidney, so pelvis, ureter, bladder, all those things are going to trigger the micturition reflex. All right. You should review, and I said this before, that we've covered this a couple of times now, the renin, angiotensin, aldosterone mechanism. You should know that like cascade, okay? So I went over it a couple of times in the previous review. You can look at the slide that shows you the different events. You should know what triggers the release of renin, low blood pressure, and then you should know what happens after that, okay? So how do we get to aldosterone? If you know that, you should be able to answer some basic questions about it. You don't need to know all the ins and outs and all the details, but you should be able to figure out like how to answer certain questions just based off of knowing a little bit about that mechanism. What is stated on the PowerPoint slide is more than enough. Again, another question about reabsorption, particularly this is talking about at the distal convoluted tubules and the collecting ducts. So the main thing that's being reabsorbed there is pretty much the same thing that was being reabsorbed at the proximal convoluted tubule: water, sodium, chloride, and anything else that's considered an electrolyte or water that we don't want to void out. And this is actually why we have like antidiuretic hormone and aldosterone being secreted, because we can actually manipulate using those hormones what substances we keep and what substances we decide we need to get rid of. So if I don't need to conserve much sodium or much water, then I'm going to see a downregulation in aldosterone and antidiuretic hormone. So you actually void out more water, more sodium, more chloride. But if I need to increase my blood volume and I need to conserve some sodium, then we are going to see an increase in aldosterone secretion and an increase in ADH secretion in order to conserve. But that conservation is at the distal convoluted tubule and the collecting ducts. I talked about diabetes insipidus, and I told you that that's a problem with ADH, antidiuretic hormone. We'll talk more about diabetes mellitus in the digestion chapter. That's more of a insulin problem, or is an insulin problem, and we'll talk about that. But what you need to know is that the term diabetes really comes to the point that it's describing kind of the symptoms associated with that disease. So diabetes has two very common symptoms, whether it's diabetes insipidus or diabetes mellitus, and that is excessive thirst and excessive urination. So excessive thirst is known as polydipsia, okay? DIPSIA, polydipsia. And then excessive urination is known as polyuria. So poly and then URIA, polyuria, okay? So those are the two characteristics. So diabetes in and of itself just means excessive thirst, excessive urination. Then with some testing, you decide or you determine, is this a ADH problem, hormone problem, or an insulin hormone problem? And that's what differentiates insipidus from mellitus. All right. And then this will be something I'm not going to give too much of a clue, other than we talked about specific areas that are going to secrete certain things, and I talked about where renin specifically comes from. So that'll be the one clue that I'll say is, like, we know it comes from the kidney, but I've also alluded to or even said explicitly, like, where it's coming from, like what cells are involved. So I'll let you review that just in case you don't remember. So, all right. So that's the test. It's 50 questions, multiple choice. I'm going to stick with this. I will also post the key for the chapter review questions, just in case you need them. But I would say review this and the previous review videos, audio, however you consume it, and then go from there, because I just basically read off the test. I skipped a few things. I left a few things that I think you'll be fine with, or some things that hopefully, if you've done your chapter review questions and your course outline and you've been paying attention to the class, you should be able to answer those questions. So, all right, I'll see you in class the next time I see you in class.